Hello everyone, welcome back to another session in dentistry and more. We are continuing our question paper discussion on pediatric dentistry and we are into the second part of mini sessions. And this session also we are having very important questions lined up. So we'll be checking one by one. The first question was in the chapter growth and development, and it's a very commonly asked essay question, the development of occlusion from the gum path to the mixed dentition state and its clinical relevance. And as we all know, the eruption begins at 6 months of age and there will be spaced dentition. The usual spacing between the teeth in deciduous dentition is known as primate space or physiological space. Some will be like non-spaced dentition. So if the physiological space is not present, there will be definitely crowding in the permanent dentition. And we have the terminal planes, that is future molar relations in deciduous dentition as distal step, then the flush terminal plane and the medial step. So in future the medial step will become class 1 or class 3 depending upon the movement of mandibular teeth. Ideally it will fall into class 1, whereas flush terminal plane it will result in end-on relation or end-to-end relation, and the distal step will result in class 2. And anterior teeth relationship, there can be overbite, edge to edge bite or overjet, and canine relationship and arch dimensions. Whereas mixed dentition period, we have first transition period, intertransition period and second transitions period, and all we know the Broadbent phenomena, where the ugly declining state, when the canines are getting erupted, it pushes the lateral incisor, it in turn pushes the central incisor, and once the eruption of canine is complete, the labial displacement, the distal displacement of these central incisor will be normal and the teeth will be in an aligned phase. That is a transient state of malocclusion, because this canine will pushes the roots of lateral incisor, thereby it transfers the force into the central incisor root. So there will be divergence and there will be a diastema, temporary diastema present, but once the tooth erupts it will be okay. So the next question is growth and development and the theories of growth and development. So you already studied all these theories in your ortho textbook. So the same theory you need to write it again. So growth by definition, it's a dynamic process with stable patterns of changes resulting in increase in physical change of mass during the course of development. So many scientists given definition Stewart as development increase in mass, increase in size by profit. Moyer says quantity aspect. Todd says growth referred to increase in size, whereas development is increase in complexity. Moyer says naturally occurring unidirectional changes in life of an individual from its existence as a single cell to its elaboration as a multifunctional unit. So we know theories of growth, there are lots of theories. The most commonly we see in genetic theory, sutural theory, cartilaginous theory, von Limburg's theory, functional matrix theory, Enlow's expanding with theory. All we studied in ortho, not explaining one by one because you already studied all these theories. Just for example, functional matrix theory claims that origin, form, position, growth and maintenance of all skeletal tissues and organs are always secondary, compensatory and necessary response to chronologically and morphologically prior events or process that occurs in specifically related non-functional skeletal tissue. Okay, so it has skeletal unit, functional matrices. Again, it is divided into microskeletal and macroskeletal, capsular and periosteal. So that is most important theory, functional matrix. You already know it. Next, we have the terminal plane relationship. Mention the classification of terminal plane relationship. We already seen this. That is mesial step, distal step, and flush terminal plane, and how it is becoming in class 1, class 2, class 3, and end-on relation in the future permanent teeth. So next question is growth spurts define and add a brief note on significance. So we all know growth does not take place in a uniform manner at all times. There is a sudden spike in growth at certain age groups. That is just before birth, 1 year after birth for mixed condition time. The boys' growth curve will be in an exponential phase at around 8 to 11 years, and girls for 7 to 9, and even for adolescents exponential growth seen 14 to 16 year for boys and 11 to 13 year for girls. So that is known as growth spurt, the sudden exponential accelerated growth compared to the other time period. So it is the best time for interceptive orthodontics. That is the most important things. We can remodel the growth. We can make changes in the bone growth. The orthodontic treatment is done earlier in girls as the growth spurt is early. And the earlier the onset of puberty, the smaller the adult. And girls mature earlier but also finish their growth sooner. That leads to difference in the adult size of men and women. And regarding the malocclusion, which requires surgical correction, should only be undertaken after the growth spurt is completed, because if any correction is done before the growth spurt, there will be chances of change in the relapse of the already done corrections. So always this surgical correction should be done only after the growth spurt completion. And class 3 tendency with mandibular prognathism should be treated before prepubertal growth spurt. Class 2, class 3 malocclusion should be treated during the growth spurt. Arch expansion can be done also during the growth spurt. Also, it always helps the expansion, because we can use the potential of growth spurt. If the jaw growth has to be accelerated, it has to be done before the adolescent growth spurt in girls. And next question is chronology of eruption of teeth and how chronologically the teeth erupts. We know first tooth erupts the central incisor, that is the lower central incisor, then the lateral incisor lower, then comes upper central, then upper lateral, then comes the lower canine, the first molar, then comes the lower canine, then comes the upper canine, then comes first molar. Before the cuspid there is upper first molar. You just see the order. This is given in months. Similarly, in the permanent teeth also, we know the first tooth erupts is the first molar, and we also having lower central incisor erupting in the same period, then the lateral incisor, same time there will be upper central incisor. So you can just go through this table, that is chronology of eruption of teeth. Next question, write 4 characteristic clinical features of primary dentition. We can write many characteristic features of primary dentition. It can be related to enamel, dentine, pulp, root, the crown length, the crown shape, the color of enamel, the translucency of enamel. So everything, you have so many things to write in primary dentition and permanent dentition difference. The few are pulp cavities are larger in primary, enamel and dentine are thinner, enamel bulge at cervical ridge rather than taper gradually. Crown of primary teeth are more bulbous, often having labial and buccal singular. Now the most important short note, that is a leeway space of Nance. So what is leeway space of Nance? You need to draw this picture. That is a mesiodistal width of permanent canine and premolar. Okay, so you can see this is the two premolars and canine. This is a permanent teeth, and here we have canine and two deciduous molars. So this excess space, this small excess space, okay, so we need to see the difference between these three teeth, that is the deciduous, canine and molars, with respect to its successors, that is canine and premolars, two premolars. So that is a difference in mesiodistal width of permanent canine and premolars with that of canine and molars. So always there is a difference, that is 1.8 mm in maxilla, that is 0.9 on the left side and similarly on the right side, and a large distance is present in the mandible because molars, lower molars are very wider mesiodistally. So that is why this is very larger, 3.4 mm in mandible, that is 1.7 on one side, whereas it is just 1.8, that is 0.9 on one side. The difference is not as large as seen in mandible. This excess space is called as E space. This is mentioned by Nance, so it is known as leeway space of Nance. So what are natal and neonatal teeth? So natal teeth which are present at birth, neonatal, that teeth erupts during the first 30 days. So natal teeth are encountered more often than neonatal in the ratio of 3:1, and it is more seen in females. Baby girls. Teeth affected are lower primary central incisor, then maxillary incisor, then mandibular canine molars, and the least reported one are maxillary canine and molars. Etiology could be or any of these or all of these multi-system syndromes or any genetic abnormalities, trauma, hormonal stimulation, or superficial position of developing tooth germ. And there is a classification for these teeth: class 1, class 2, class 3 and class 4. Shell-shaped crown poorly fixed to the alveolus by gingival tissue, that is class 1, and there is no root. In class 2, solid crown and little or no root. Class 3, eruption of the incisal margin of crown through gingival tissue. Class 4, edema of gingival tissue with an unerupted but palpable tooth. So we can take radiograph to determine the amount of root development. Then gingival inflammation around the erupted teeth is controlled by chlorhexidine gluconate. This is all about management. So sharp incisal scan laceration of ventral surface of tongue, which is known as Riga-Fire disease, or neonatal sublingual traumatic ulceration. So selective grinding is advisable. It may cause difficulty in breastfeeding, and leave the tooth in place. Explain the parents the desirability of the tooth, which is important for the growth. So unless and until it creates so much a problem, we don't need to extract it. Now we have the primate space, that is also known as anthropoid and simian space, which is present between the lateral incisor and canine on the upper teeth, and between the canine and first molar on the lower teeth. That is the space present mesial to the maxillary canine and distal to the mandibular canine. So in upper it is 1.7 millimeter, and it is in lower it is 1.5 millimeter. It helps in early mesial shift, and leeway space of Nance helps in late mesial shift. So physiological space is a natural space between all the teeth, but primate space is particularly which is present mesial to canine on upper and distal to canine on lower. Leeway space of Nance is the difference between the canine and molars, deciduous canine and molars with respect to its successors, that is the canine and permanent premolars. So what are the self-correcting occlusal anomalies? We have so many anomalies. That is retrognathic mandible. It will be ready by as growth cessation happens by 17-18 years. Anterior open bite will be okay by the eruption of teeth, and posterior teeth. Infantile solar will be okay. All are self-correcting occlusal anomaly, and there is anterior deep bite. It will be automatically corrected. Flesh terminal planes will be corrected. Space dentition will be corrected. Primate space, ugly decline stage, all will be corrected once the permanent teeth erupts. So ugly decline state we already discussed during 8 to 11 years. What happens is when the eruption of canine starts, it impinges on the roots of lateral incisor. So this lateral incisor in turn impinges on the roots of central incisor mesially. So what happens is the crown moves towards the distal side. So both the crown of central incisor moves towards the distal side. So there is a gap present in between the teeth. It looks like midline diastema, and the child feels ugly. But what happens after few after the 1 or 2 years, once the canine erupts completely into the oral cavity, the force transmitted to root now transmitted to crown. So this distally pushed tooth will be pushed medially from either side, and it will be aligned completely. So it is a metaphor of ugly duckling, where the duckling was not looking good when it was just born. After a few years, when it is completely grown, it is very beautiful swan. It became a beautiful swan. So it is a metaphor for the temporary looking ugly of 8 to 11-year uh, kids, where they feel like they are very ugly because of this presence of midline diastema. But it will be easily corrected automatically within 2 to 3 years, just like how the ugly duckling became a beautiful swan. So this is a difference in primary and permanent dentation. We know primary is lighter in color, this is darker. Duration 6 to 5.5 years. This is 6 years starting, and smaller in dimension. This is very larger. Mesiodistal more than cervicocclusal. This is cervicocclusal more than mesiodistal. Narrow occlusal table in primary, wide table in permanent. Enamel 1 mm thick. Enamel is thicker, that is 2 to 3 mm. Contact areas is more on gingival, but it is on occlusal. Mamelons are absent in primary but present in permanent. First molar always smaller than second molar in primary, but it is opposite in permanent dentition. So features of primary dentition according to Bomi, that is, it divided dentition into spaced dentition and non-spaced dentition. Spaced dentition, the spaces will be utilized for the adjustment of the permanent successes, which are larger than the deciduous one. So naturally there should be space in the deciduous dentition, otherwise there will be crowding in the future teeth. That is the primate space or anthropoid in simian space. That is, we already seen mesial to maxillary canine and distal to mandibular canine, which helps in early mesial shift. Whereas physiological spacing is present all over the teeth, that is 4 mm in maxilla and 3 mm in mandible. If there is no space, there will be crowding. This physiological space is the space present between all the deciduous teeth. But this primate is particularly mesial to maxillary canine and distal to mandibular canine. And importance of chronology of tooth eruption, that is the disturbance of normal sequence and ages of eruption are one of the contributing factors in development of malocclusion. It should be erupted and new tooth should be in position of the deciduous tooth in exactly at its chronological time. Otherwise there will be crowding, there will be labial eruption or lingual eruption. So it will result in malocclusion. So, and also to avoid the damage in permanent tooth bed, and this age predilection of unknown patients in archaeological and forensics, all can be done by knowing the chronology of tooth eruption and maturity assessment or assessing the growth. All can be done by understanding chronology of tooth eruption. Teething is nothing but the problem the babies face when the teeth erupts into the oral cavity. Mostly, it will associate with pain, inflammation, malaise, disturbed sleep, facial flushing, drooling, bowel upset, loss of appetite. So it is we can manage it by teething rings or sugar-free teething rice cucumber peel can be given. If pain is there, analgesics or antipyretics can be given. Topical anesthesia will give some soothing effect. So that was all about this session. So we have many sessions coming up. So next sessions also will be dealing some very important questions in pediatric dentistry. So thank you.